When we think about assessing symptoms in palliative care, there's a lot of things we need to consider. One of them is time constraints. We don't always have a lot of time, and busy clinicians will not use assessments if they think it's going to take up too much of their time or burden patients and families. And the beauty of the Edmonton symptom assessment system is it can be done in 30 seconds or less sometimes. It's simply 9 different symptoms, for example, pain, nausea, depression, anxiety, well-being, and a few others, with different anchors from 0 to 10, with 0 not being a problem and 10 being the worst that someone can imagine. And you ask the patient to fill it out for how they're feeling right now at this moment. There's a lot of discussion for whether it should be right now or the last 24 hours. We chose right now because even people with some degree of cognitive impairment can generally tell you how they're feeling right now, even if they can't remember what they had for breakfast. And that was a part of the rationale for choosing that. That is a way of describing it. But it needs to be understood as unidimensional. It's just a snapshot. And there certainly are a lot more ways that you can tease out the nuances of pain or well-being, for example, is set up as the quality of life question. It essentially says, given all the symptoms and psychological fears, how are you feeling right now? It's the how are you question. So in one visual analog, but it's very unidimensional. Obviously, to understand what people mean when they give you a number requires a more in-depth conversation. But sometimes the fact that people give you a high score that you may not have anticipated for depression, for example, is an opening to ask people more about that particular symptom. And of course, there's very complex assessments we can do for pain using things like the brief pain inventory or a number of scales for depression and quality of life and so on. And some people may choose to use some of those in some patients. But for the average clinician, having a simple way of doing things as a standard and considering other options if you want to do a more complex assessment is helpful. And obviously for research purposes, something like the ESAS would have limited value for someone doing a complex research study where they're trying to get at numerous complex themes. But we're trying to balance these many different things as we do clinical work and research.
I'm thinking it's either you or you. Now, you because you're hooked up to a bunch of machines, or you, well, you just have that look of someone who's going to die young. I'm kidding. You're going to live forever. Or not. I mean, what do I know? I mean, I'm not psychic.
We did not like him.
I think he's funny.
She's delirious.
Mrs. Wilk, I'm Dr. Hedrick. Now, it sounds cliche, but you're going to go through what we call the 5 stages of grief, which are denial, anger, bargaining, depression, and finally acceptance. Now, I assume that you two have already entered into a conversation with Mrs. Wilk about what the process of dying is going to be like.
We were doing it right before you came in.
Oh, well, then, I'm sorry. Then please continue.
All right, we will. Newbie. Go.
Oh, okay, well, yeah. Okay. Death is like a journey. A journey in a boat, and then this giant light shines down on your boat and carries you up to the heavens.
That was the ending to Cocoon.
Take it away, Coxie.
How do they teach you how to tell someone that they're dying? It's kind of like teaching architects how to explain why their building fell down. Do you role play and stuff?
Yeah, one of us gives the bad news and one of us gets the bad news.
What do you have to do to get an A in You're Dying 101? They grade you on gentleness and supportiveness, sort of scale for measuring compassion. This buddy of mine, I gotta give him $10 every time someone says thank you. Imagine that. This guy is so good. People thank him for telling them that they're dying. And that's brown. I don't get thanked that often.
Hey, check this chart out. This guy says he's been in pain for like 3 months.
For doctors, pain is complicated. Every patient handles it differently depending on their race,
Does what hurt?
gender,
Ow! I just bit the inside of my lip. Ah! Nothing has ever hurt so badly.
or even their sex life.
Oh, yeah, that feels good.
And since there's no way to truly gauge how much pain someone's in, we have to rely on an archaic chart.
Mr. Peel, you're about a 7 on the pain chart. Yep, you're a 7.
What's a 10?
That's a 10.
Hey, Carl.
Hey, Rooney, come here for a second. Carl look a little odd to you? Is it me, or does he look like he's kind of dead?
Nope. No more than usual.
I don't know. Kind of leaning towards thinking he might actually be dead.
I guess I never saw him a lot, so it's hard for me to tell the difference.
Yeah, that's true. He never did much. Wasn't a good friend. Wasn't a good anything. Hey, there more beers in the fridge?
Oh, sorry. Last one.
Oh, that's upsetting. Ooh, shit.
Je bent heel erg meer benauwd geworden hè, in het weekend. Ik denk dat we daar zo vlug mogelijk iets aan moeten proberen te doen. U hebt al morfine tegen de benauwdheid. U krijgt een drank. Ik ga nu een injectie morfine onderhuids geven. Te proberen zo snel mogelijk wat verlichting te geven. Dan kunnen we daarna bekijken wat we in de komende dagen verder moeten gaan doen.
Kind of like his protege.
You see his chart, touch screen,
copied and highlighted.
Unfortunately, Radar, I'm fresh out of gold stars. Up to low bar pneumonia at 31. How much does this guy smoke?
I don't know.
You realize, of course, it's your attention to detail that impresses me most. How many packs a day, genius?
Half a pack.
Oh, I'm sorry. I phrased the question wrong. How many packs a day, really?
11. Now you don't know where I'm coming from. 2 or 3 packs.
Well, let's hear it.
Oh, I don't smoke, so 0 packs.
What tests have you ordered?
Oh, I know. I was totally kidding with you.
He was. We're all in on it.
I like Will. That actually makes this harder. I ordered blood cultures and a high-resolution CT.
Well, what are you looking for?
Cancer.
When you say the word cancer, every person reacts the same way.
Excellent.
Not like that. There it is.
Now let's take a couple cases and see how we might think of them in our own clinical assessments. So Janet's a 47-year-old woman with advanced ALS. She has never married, and her only living relative is a sister to whom she has never been close personally or geographically since childhood. She has friends in the community who visit her regularly, so she is not socially isolated. She has struggled valiantly through the insidious progression of her disease until recently, when she has repeatedly expressed a desire to, quote, lay down the burdens, unquote, of her terminal condition. Her severe muscle weakness requires intermittent respiratory support. She's concerned about the possible clinical depression, that is, her clinician. And so her physician engages a consulting psychiatrist who confirms she is not clinically depressed and definitely has decisional capacity. Janet repeatedly expresses concerns about the impending loss of her dignity and control over her situation, and believes that the burdens of her life, at least to her, significantly outweigh the benefits of her struggling on until she dies from the underlying condition. Although not religious, she accepts reluctantly spiritual counseling at the insistence of her physician. This counseling, however, fails to change her overall view, which is that she wishes to have palliative sedation. And this is what she repeatedly expresses to her physician, is her request and her strong desire at this time. And by the way, she says, once you have done that for me, which I hope you will do, there is absolutely no reason to provide artificial nutrition and hydration. Should the physician honor her request? Now, it all depends, as we can see, on which guidelines and policies one follows. If one is inclined to rigorously follow the AMA policy, it's entirely within the realm of feasibility that the clinician will say that this patient is suffering from distress of an existential nature. She's not imminently dying, and therefore total sedation, palliative sedation, is not a viable option for her. And I have to go back to her, tell her I will suffer with her, pursue more zealously forms of relief for existential distress that don't involve a barbiturate coma, whereas if I rather, just go back here, if I am among those who follow the guidelines of the National Hospice and Palliative Care Organization or the American Academy of Hospice and Palliative Medicine, I will say this case may well be one in which I can reasonably offer palliative sedation to this patient. Let's take another case. Joe is a 30-year-old with end-stage osteogenic sarcoma. After years of surgery and chemotherapy, cure is no longer a reasonable goal. Joe's developed myoclonus as a side effect of prolonged high-dose therapy from opioids. Despite adjuvant treatments, the pain is worsening and responds only to escalating doses of opioids that exacerbate the myoclonus. Joe's groggy but alert when his physician discusses with him and his family the option of total sedation. With support from his family, Joe provides informed consent to total sedation and to the provision of artificial nutrition and hydration. Increasing doses of benzodiazepines control the myoclonus, but the dose required precipitates a coma. Joe dies 2 days later as he remains in that coma. Was his physician's conduct ethical? Now, even some of the more conservative analysts and commentators in this area have suggested that this case is unqualifiedly within all reasonable realms of palliative options of last resort, because this is what you would call sedation of the imminently dying. And they will also suggest that it can be justified by invoking the doctrine of double effect and saying that providing the barbiturate medications here that totally sedated Joe was done for the purpose of ensuring he did not suffer, and also for addressing the problem of exacerbated myoclonus. It was in no way, shape, or form a way to manage existential distress or in any way hasten his death. But if we move on to a third case, we have The patient, Bill, who's 56 years old, suffers from a glioblastoma, the left frontoparietal area. Following a discussion with his family, Bill decides to forego additional radiation therapy. He urges his physician to focus on symptom management. Anti-seizure and adjuvant pain medications are administered. Bill routinely experiences focal seizures followed by severe muscle weakness. Bill expresses fear of losing control of his life and asks his physician for help to end this quickly. His physician informs him that intentionally hastening death by the administration of prescription medication is against the law in their jurisdiction. However, he says that Bill should be aware that it is within his power as an autonomous patient exercising his free will to decline further nutrition and hydration. And as a consequence of that, given his underlying clinical state, he would probably not survive more than 1 to 2 weeks. His physician promises to support such a decision and ensure that if he goes that route, his dying will be comfortable because any palliative measures that may be necessary to address the distress from his withdrawal, foregoing of food and water, will be provided. Bill stops eating and drinking shortly thereafter. 1 week later, he becomes severely agitated, and his physician prescribes sedating medication to ensure Bill's comfort. And 2 days later, Bill dies. So the question then arises, how should we characterize Bill's death? Within the taxonomy of euthanasia, for example, from a causal perspective, what was the cause of Bill's death? And what was the physician's role in this? Now, from a direct causal analysis, the physician didn't cause Bill's death. Bill died from the lack of nutrition and hydration, more probably hydration, or perhaps from the underlying condition. It's hard to parse that out. But this and the previous 2 cases were taken from this article in the Annals of Internal Medicine by Jansen and Somazi. And they would suggest a critique of Bill's physician here as, in a sense, collaborating with Bill in bringing about his own death in a hastened form by refusing nutrition and hydration. They don't say that this is categorically wrong, but they suggest that some physicians might, in the exercise of their conscience, choose not to go this route, and their conscientious decision to decline to even offer or suggest this option to a patient should not be the subject of moral critique. I want, with your permission, to go back briefly to the first case because there was a secondary question that we should consider, because this case was framed the way it was as a 2-part question. The first was if Janet did not decline artificial nutrition and hydration after total sedation was provided. And I don't want to leave anyone with the idea that if she had not accepted nutrition and hydration, if she had said, once I'm totally sedated, I do not want nutrition and hydration, would this make it morally problematic in some way? I'm sorry. It was case 2 in which that was the alternative. In the case of Joe, what if Joe had said, just as Janet had done in the first case, I don't want artificial nutrition and hydration? Would this have changed the ethical posture of the case? And I would suggest to you that it would not, because it goes back to that prior point. These are 2 separate decisions to make, and there's nothing that morally compels the physician to provide or for the patient to receive artificial nutrition and hydration once the decision has been made freely and with informed consent on the part of the patient to request total sedation, and the physician has decided they're comfortable providing it consistent with their own sense of what ethics and professionalism require in the care of patients who have intractable suffering at the end of life.